Well, good evening, everyone. I'm really delighted to be here. Hopefully this will be a prime moment in our rejuvenation of the blood supply in here in the Pittsburgh area. This time last week, I was in Harrisburg, invited there to represent Vitalant, the state department. Some of you may have seen some of the feeds, some of the news from this. The state actually, this is on the agenda, the blood shortage, the acuteness, and getting more donors in the pipeline is on the state's agenda, and the State Department of Health and Dr. Denise Johnson, who's the director currently, sponsored 5 blood centers from across the state of Pennsylvania, and so we were represented. We had media coverage, and so it is getting attention, not just here. We're carrying it through the state and the national level, hopefully. I'm also, just by way of background for me, I'm a blood banker, but I'm also a practicing hematologist. So I have patients that Charlie mentioned that got these units of blood. I have patients that literally, from the time they were 13 years old, they're in their 40s now, they've gotten thousands and thousands of units of blood. Mostly plasma because of the kind of diseases I treat. But, they're not constantly singing the praise of people who donated the blood, but they appreciate it because I see the look on their face and I see the impression that it makes on them. And so we have multiple types of patients in our area that need blood. What I was going to do is, first of all, start off here. You may have heard about this in December. This was, the headline here was 45 million gallons of crude blood lost in Red Cross pipeline rupture. And this was in Las Cruces. I've been to Las Cruces. What is being called the worst blood disaster in U.S. history, the Red Cross Western Blood Pipeline ruptured Tuesday evening. Now, I'm glad I'm seeing some smiles on some faces here. I hope everyone in the room realizes that this is not the way blood is transported. It's much more laborious. And of course, people are commenting here, wow, this is real blood. I never knew they did this. Damn, this is going to take years to clean up. Thank God we don't do it this way, at least not at Vitalant. Maybe other blood establishments do it, but this was, really a ruse. But I'm going to teach you a few blood facts. I think Charlie's done an amazing job of really prepping you, and I don't need to spend a lot of time on this. And I think, the quote is up to 3 lives. It's more like, to be fair, it's more like 2 lives now because we get platelets directly from donors rather than taking it from a unit of whole blood. So we get plasma and red blood cells, and those are listed for you here. I don't have a pointer, so I can't point them out. But we have elements in the blood, all of which are useful as products to help patients in need of those products. The donation process, any of you who have donated here are familiar with it, and I want to also extend my personal thanks for you making the time, to Mark for organizing this, for the Blood Science Foundation and all the tremendous efforts they've been behind all along to support this. And really, I want to personally thank you. Many of you are familiar with this, and the point here is it doesn't take all that much time. Charlie made the point that this is a real way, and hero is an overused term, but this is a real way to share your own good health and really help people who are needy. And it's such a really simple way. Most of the time, this takes less than an hour of your time, and we have ways to try to expedite this process too. But it basically is screening donors. It's taking their blood by the donation. This is whole blood. We have apheresis donations. We have various levels of commitment, but the easiest thing is whole blood, which takes literally 10 minutes on average. And I'm just going to highlight some of the information from these slides. Charlie mentioned the emphasis on safety. We have to pay attention to the safety of the donor as well as the safety of the recipient. Now, the safety of the recipient and the blood supply is really paramount, but I get called frequently during the day about donors who want to donate that have one or other medical issue, and is it wise for them to donate? And sometimes we tell them yes, sometimes no, sometimes wait, sometimes check with your doctor. But we really have a tremendous safety record both on the donor side, which is monitored, and the FDA monitors donor injuries and mainly many serious adverse outcomes from donation, but we also monitor on the patient, the recipient side, and we're really tuned into these elements. So it's a really tightly knit process. I thought I'd show you all the things we screen for in blood. I'm mentioning 10 different diseases, and I started off as I was a hematologist, but I became a blood bank fellow in 1985, and at that time there were only 2 tests we did on blood. And that's because it was realized that you can actually contract syphilis from someone who has active syphilis, and you can contract hepatitis. And when I was a fellow in 1985, you see there about halfway down, the anti-HIV test came out, and that was in the middle of my fellowship. So at that time, this was really a monumental achievement for the testing, for this to go into place. We had to notify recipients of blood that got their blood last week that now we have a donor who's positive, and their blood that they got was positive. This is a tremendous, tremendous effort that took place. And over these decades that are showing by these dates here, that there are now really sensitive and specific testing for the hepatitis testing. Hepatitis C came about. Harvey Alter, who got a blood banker, who got the Nobel Prize 2 years ago or 3 years ago for the co-discovery of hepatitis C virus and the testing for hepatitis C virus. Actually, no, a Nobel Prize winner that happens to come from the blood banking field. Some of these you may or may not have heard of. There's actually one error I want to point out. I want to recall this slide right now. Those of us in blood banking know about recalls. And the West Nile that statement about West Nile viruses actually should be under Zika. That's now been Zika. Now we have COVID. We don't have Zika. So there are these epidemics that come out. A lot of the diseases now are not endemic diseases, but they're epidemic diseases. Fortunately, COVID is not transmitted by blood, so we didn't have to worry about it. But there was a concern when COVID first came out, and there were reports from China that, hey, we detected RNA in people's blood that were infected with COVID, but it turns out these were not live transmissible viruses. So we dodged that bullet. Just to point out, that's the 10th one. There's bacterial testing of platelets. Platelets, because they need to be incubated at room temperature or kept at room temperature, if you happen to have a bacterial contamination of the platelet unit, it can actually cause sepsis in the patient. And then, of course, if you're a mosquito, this is a good time for you. And a lot of these have been mosquito-borne illnesses that we've talked about here and there. But any idea what these mosquitoes are drinking at the bar there, mosquito bar? They're Bloody Marys. That's what they're having. I wanted to mention, and Charlie touched upon this too, how often we go to donors and the rules that are really set for donor safety. We have donors that get upset with me if I say, no, you're donating too much. We're seeing some evidence in your hemoglobin, whatever is coming down, you should take a break. They get upset with me because they're told, you're donating too much, you have to take a break. That's called a deferral. And of course, we don't like to do that, but sometimes we have to do it. But these are the rules that the FDA has set out for how often you can donate. 56 days for regular whole blood. It's double that if you're donating double red cells. It makes sense. You're losing twice as much hemoglobin, twice as much iron. For apheresis platelet donations, you can donate twice a week and 24 times a year. And for plasma, it's about once a month. It's about once every 28 days. So these rules are scrupulously adhered to. We actually have rules that have been put into place to say, well, if a donor's reaching their limit, I get called if it's getting close to it or whatever, whether we can allow the donation or not. And when we had the convalescent plasma, which some of you are familiar with, people that had contracted COVID and then were able to donate their plasma to us, we took some allowances in those rules. The FDA said that we could do that, and we took them a little bit more often to donate their plasma because it was for a very good cause, and there was a pressing need for convalescent plasma. I just thought I'd walk you through a little bit just to give you a little bit more, because the people that you may be related to donate blood may want more information, and I'm not going to go into any great detail. You don't have to remember any of this, but there's a mini donor health screening every time you donate. We're checking your vital signs, checking your hemoglobin by finger stick. We're taking a look at the skin areas. I've donated so many times that we actually have to avoid scar tissue, because scar tissue can hold bacteria which can get into the unit of blood and cause an infection. So our actually procedures, and these come down from our FDA procedures and so forth, is we have to avoid those or not take those particular donors. And they may be a sign of something else. There's a donor history questionnaire. It is very much standardized. It's not most blood centers, it's all blood centers now. This is I borrowed this from an older slide. It's currently 50 questions long. And, it takes a few minutes to do this as a donor. But the good news, and they have to do with a few personal questions about your health status, but mostly if you have a risk behavior or a disease or something, or taking a medication that could cause harm in a recipient. And so these are all excluded. It's all automated now. And the good news here is we have a bypass here called Donor Pass, that you could fill this out that day and save time at the donor center to get through your donation at the site pretty quickly. I thought I'd touch on a few myths involving blood donation, because this gets to the issues, again, Charlie was referring to about the reticence, the tendency people say, no, it's not for me, I can't do this because, and they fill in the blanks. Now, we understand fear of needles. Back in the old days, believe it or not, the blood bank actually had a mascot, and someone got the bright name of naming the mascot Needles the Bear. It's probably not a great name for a mascot. It probably should have been something else, but that's, fear of needles is a legitimate thing. We can, by seeing examples and experiencing it your first time, you can get through. But some of these myths maybe they're more excuses than actually reasons. But I have a medical problem. I have high blood pressure. What's this going to do to my blood pressure? Diabetes, elevated cholesterol. Most of these common ailments, as well as most medications that people take, are acceptable. Now, we do exclude if you're being treated for an infection. Again, we're worried about infection affecting the blood. If you're on a blood thinner, we won't take you. Why? It may affect the potency of the blood, but also it can affect the risk of a hematoma. And, I deal with that periodically. It's a relatively small problem that is there, and we train people and teach people to deal with things like that. So most conditions are fine to donate. I thought Charlie talked about tattoos, and the FDA actually did us a big favor. I think they were also responsive to the industry, saying, look, can we simplify any of these deferral periods? And they came down with a lot of them from 12 months to 3 months, basically because the testing is really that good. Just for vaccines, the point about this slide is most of them, like flu vaccine, things like that, there are no deferrals. A couple of them are live attenuated viruses or bacteria that can have a little bit longer time in the blood, that need either 2 weeks or 4 weeks, and our donor screeners have all this information down. And then the nice thing about the COVID vaccines, there's no deferral period for COVID vaccines. One of the things we get involved with, and again, this was mentioned earlier about the shortage. What do? Well, we try to apprise hospitals what our blood situation is so that they can make preparations. The worst scenario is not to be informed if there really is a severe shortage coming up. We have levels or layers of concern. We give advice to hospitals to talk to them about whether it's a business as usual, and you can think about it as a green light, a yellow light, a red light in terms of blood supply. But we'd like to, and it's especially for some blood types, O blood type, and the Rh negatives are almost always in short supply. And as a result, I don't know if you noticed when Charlie showed the slide about our numbers of donors and donations, Well, I'm sure a lot of you were doing the math in your head. You came up with a number of donations per donor, and that's an average of 1.7. I did the math, not as I was sitting there, but 1.7 donations a year. Well, the old number, this is an average, right? It's all the donations and all the donors, so it's really on an annual basis. We tap into the O donors much more often than that. They're asked all the time. I'm an O donor myself. The Rh negative donors, we go to them a lot, and there is a natural burnout, really, and that's the other thing about donating blood. It's not you haven't been asked, but you've been asked too much. So we constantly need to replenish and, to use a hackneyed phrase, get new blood in the system. We always need new donors to take up for people that are older. Maybe they have a medical illness that they need blood at some point, as Charlie also mentioned. We also are constantly changing. Change is part. I showed you all those tests, the years that those tests were put in. We now have been given guidance, final guidance by the FDA, and we're about to implement a change in our platelet testing procedure. We test all platelet donations for the possibility that they can contain bacteria, and we're going to have to actually shrink the time that those platelets are available on the shelf because of not the large volume, but the delayed sampling. We're waiting a little longer to allow any bugs in the bag to grow, to allow a safer platelet product. So we're always improving the safety profile of blood and improving the chances for patients to get a benefit rather than an adverse outcome. And I have to say, over my decades of experience, we've done that very successfully from all the major things that we used to worry about in our transfusion committees. We also have a new thing on the block. We haven't really started this yet in Pittsburgh, but it's available. The FDA's model here is to make blood eventually into a pharmaceutical product where it will be treated with an agent that will destroy any viruses and bacteria. And we now have this available, at least on a national scale. This has been licensed, and pathogen reduction technology is just now starting to enter the fore. This is a little bit more expensive, but it's also a way to ensure safety of the blood supply for transfusion recipients. So I just want to close there by, I think fundamentally we are optimists. I have yet to, and Dr. Triolzi will speak to this a little bit more too, I have gotten close to cutting surgeons off, having to get on the phone with a bleeder or anesthesiologist. Dr. Waters is here as well, saying, look, we have 5 more units we can spare. And I have not heard that that's made a difference in outcomes yet, but we're close to that, and we really do, literally worry about that every day. I'm fundamentally an optimist, and some people ask me, are you a glass half full or a glass half empty person? I say, that doesn't matter to me too much. I just want to know who the hell drank my wine. Thank you.